Okay, hi everyone. This is Dr. Massenkai. I'm here with Dr. Mark Menemeyer.
Hello, everybody.
Hey, and we're going to be talking about behavioral neurology and really focusing a lot on the neuroanatomy of that. Our objectives today, really, we're going to talk about the anatomy of language and aphasia syndromes, and then we're going to talk about some of the anatomical basis for some of the common lobar and hemispheric cognitive phenomena. So we're going to start by talking about cognitive anatomy, and I think the first thing we're going to do is give you sort of our big picture way of thinking about these things. And the way that I think about this is that if you have a patient who has one of these behavioral neurology issues and you're out in the clinics and you're like, I don't know what's going on, if you at least think of the problems that someone can have in this way, you can at least put yourself in one corner of the brain and localize it from there. So your job is a little bit easier. So the obvious one is the left and right. So most people are left-sided dominant. So really, for convention's sake, if we say left side, kind of think of that as being interchangeable with dominant. Well, for the most part, we think about that for language. We also think about that for praxis, which we'll talk about later. Those are skilled motor functions. And then the right side, that's prosody, which is your tone of language. So the difference between you're doing a great job and you're doing a great job, right? There's a big difference there. And then attention and awareness, and then lastly, spatial representation, I tend to think of on the right side of the brain.
I think when we talk more about some of these behavioral syndromes, these functions will become obvious. One thing I wanted to add, a lot of times you'll see people associate the right hemisphere with just attention, but it's really important for arousal. When you see these patients who have big right hemisphere strokes, they're often very hard to arouse to interact with, and then once you get them aroused, they're hard to stay awake, alert, and attentive. So arousal is kind of a platform function for cognition, and we'll see that when we talk about some of these syndromes like neglect.
All right. Well, thanks for that. Let's keep going. So we talked about left versus right. The next one that we like to think about is anterior versus posterior. And I think for me, the easiest way to think about it is action, anterior versus perception. So posterior. Also, you can also think of it anteriorly as the when pathway or the when part of the brain, and the perception or the posterior part being the how part of the brain. For the action and perception, I tend to think of it as the action part being where you want to actually do something. If you want to say something, do a physical motion, that all happens there. And for the perception, that's basically you taking all the outside information, like the words that we're telling you, the pictures that you're seeing here, things that you're hearing, and making sense of it all. And then the last one that we'll talk about with these three is going to be your aware versus what pathways. And just generally speaking, the dorsal part of the brain is more of your aware part of the brain. It sort of tells you where things are in space. And then the ventral part of the brain is more of your what pathway. So what exactly are you looking at? What are the features of the item that you are paying attention to or thinking about? And then one last thing that we should bring up is the callosal syndrome, so the corpus callosum.
I mean, another big picture item is the way that the two hemispheres communicate with each other. And there are a number of commissural pathways, the anterior commissure, the habenula, but the vast majority of information is transferred between two hemispheres via the corpus callosum. And in this slide, basically, you see a brain that's got a severed corpus callosum. And then anterior to that, you have the left visual field, the right visual field. The left visual field projects to the right hemisphere. The right visual field projects to the left hemisphere. And if we use a device, to present information like visual information temporarily or in a short period of time, you can flash information to one hemisphere or the other. So if we flashed information into the left visual field, it would go to the right hemisphere. And if we asked the patient to identify what they saw, they could use their left hand to point to the object that they saw, but they wouldn't be able to use their right hand, or they wouldn't be able to tell you what they saw because that's controlled by the left hemisphere and it doesn't have that information. Conversely, if you flashed information to the right visual field and presented it to the left hemisphere, the same patient wouldn't be able to point to that information with their left hand because the right hemisphere doesn't have that information. A couple of these behavioral syndromes that we're going to talk about in a little bit, like alexia without agraphia and apraxia, both involve a component of this failure of callosal transfer. So it's another important anatomical feature to keep in mind.